Great. Thank you so much, Cameron. If you don't mind going to the next slide so everyone can see our learning objectives for today. Thank you, everyone, for joining us today for the National Alzheimer's and Dementia Resource Center webinar. It's a journey, age-friendly and dementia-capable health systems. The National Alzheimer's and Dementia Resource Center webinar series is supported by the Administration for Community Living. And before we start, Erin Long of the Administration for Community Living will provide a brief welcome. Erin?
Hi, everyone. I just want to take a quick moment to thank you all for joining us for this very important webinar. I want to thank Ronnie Schneider from the John A. Hartford Foundation and Heidi Weirman from MaineHealth, who are great partners to ACL in the delivery of services and support. So thank you very much for your time, and back to you, Sari.
Thank you so much, Erin. So as you heard, today's presenters are Ronnie Schneider and Heidi Weirman. Ronnie Schneider is Vice President Program at the John A. Hartford Foundation. Ms. Schneider has over 25 years of experience working with the preeminent healthcare institutions across the nation, improving the care for older adults, identifying and guiding healthcare programs that have set the standard for medical best practices, increasing medical education opportunities, and maximizing resources to improve healthcare broadly. She brings that experience to the John A. Hartford Foundation, where she coordinates initiatives that foster collaboration among academic institutions, hospitals, and healthcare providers to build age-friendly health systems, support family caregivers, and improve serious illness and end-of-life care. She is a board member and past board chair for Grantmakers in Aging, a membership organization comprised of philanthropies with a common dedication to improving the experience of aging. Dr. Heidi Weirman is the Division Director for Geriatrics at Maine Medical Center and the Medical Director for Healthy Aging at MaineHealth. She has been a practicing geriatrician at Maine Medical Center since 2002, when she was part of the team to start the Hospital Elder Life Program to prevent acute confusion in hospitalized older adults. She has continued with her passion for proactive care in older adults by working in the MaineHealth system, which includes 9 hospitals, as well as across the state, to advance age-friendly healthcare while continuing to be active in clinical care and medical education. She feels privileged to have been part of teams that have utilized ACL grant funding to improve the lives of older adults with cognitive impairment, as well as their caregivers. At this time, I will turn the presentation over to Ronnie Schneider to begin.
Thank you, Sari. It's so great to be here. And I'll just tell you on the front end that I'm particularly excited to be doing this presentation sort of hand in hand with Heidi, because although our foundation, the John A. Hartford Foundation, operates nationally, I am from Maine. That's where I grew up. And so I'm excited to hear about what's going on in Maine myself. So I am Ronnie Schneider. I'm the Vice President for Program, and we do a lot of work at the John A. Hartford Foundation on this topic, so it is near and dear to my heart. Next slide, please. Just a few words about our foundation. We are a private philanthropy. We are based in New York City, although, as I mentioned, we operate nationally. And we were established by the family owners of the Great Atlantic and Pacific Tea Company, maybe better known to you as A&P Groceries. And since 1982, we have focused our work on improving the care of older adults. So, gosh, at this point, we have committed over $660 million to the field of aging and health. Next slide, please. Okay, so our mission is to improve the care of older adults. And Sari mentioned, these are our 3 priority areas. This is the way we get at that mission. So building age-friendly health systems, supporting family caregivers, and improving serious illness and end-of-life care. You can see from this image, although really you just know it intuitively, that these are all overlapping areas. There is this Venn diagram. Quite frankly, that middle part is much bigger than it looks like here. We often say that you can't have one without the other, right? So we need healthcare to support family caregivers in order to build age-friendly health, and especially during serious illness. And the other thing that I'll say about our foundation, just sort of broadly, culturally, I guess, is that collaboration is an overarching theme in the work that we do. And collaboration means many different things in many different contexts. And for us, it's almost every context you can think of. Next slide, please. Okay, this is to set the tone. And really plan for that future. We all need these age-friendly solutions. So, and why? Well, first of all, demography. The number of older adults is rapidly growing and it's becoming more diverse all the time. That's something to celebrate. We have a lot to celebrate about longevity and diversity, and nevertheless, complexity. Older adults are much more likely than the rest of the population to have these multiple chronic conditions, to suffer from dementia, to be disabled, because that increases over time as we age, to have disabilities, and then this concept of social isolation. And by the way, all of these things have intersectionality with social determinants of health. Lastly, disproportionate harm. Older adults have higher rates of healthcare related harm. They suffer from what we call discoordination. And not on this slide, but also really important is in general, and particularly for older adults, poor preparation for disasters at the public health level. So I want to add to all of these things the effects of ageism. So ageism exacerbates each of the issues listed on this slide. And really, if you think about the various kinds of other isms that go with ageism, ageism multiplies the long-term, lifelong effects of other kinds of isms, if you will. Next slide, please. So I said we need solutions. Here's one. We have built the Age-Friendly Health System initiative. Really, it's a movement, and our aim has been to build this movement so that all care with older adults is equitable, it is age-friendly care, and what that means to us is these three things: guided by an essential set of evidence-based practices. We call those the 4 M's, and I'll speak about that in just a minute. That it causes no harm, and that it's consistent with the first of the M's, what matters to the older adult and their family. And so what is age-friendly care? Next slide, please. These are those 4 M's that I mentioned of age-friendly care. So they're not necessarily in any particular order, other than that what matters always is at the top, because knowing and aligning care with each older person's specific health goals and care preferences, including end-of-life care, and importantly, and you'll see this with each of the M's, it's across all settings of care, right? Because this is no matter where you go, from your kitchen table into, let's say, a hospital or a clinic, and any care after that, and then back home. So the second M on this list is medication. So when medication is necessary, using age-friendly medications that don't interfere with what matters to older adults, or to their mobility, or to their mentation across settings of care. Mentation. So mentation is anything, you could just say mind. It's anything cognitive. So dementia, delirium, depression. And the idea here is to identify, prevent, treat, and manage any of those mind-related issues across settings of care. And lastly, mobility. And this is all about function. So ensuring that older people can move in ways that are safe for them every day in order to maintain their best level of function and ultimately do what matters to them, to each of us in our communities. Next slide, please. Okay, so this is a busy slide, but it really is designed to show that we have an increasing number of stakeholders who, I mentioned collaboration early on, these are all organizations that represent people and partnerships that we work with to improve care for older people through age-friendly health systems. So just a couple of highlights for you. You can see the logo for the VA. The VA is the largest integrated age-friendly health system in the country. I was at a summit last week where the VA is across the board doing everything possible to make sure that every single VA, all sites of care, ultimately will be age-friendly health system for the veterans. That's amazing. It was a really just a stunning summit. In addition, you can see the CVS logo here. They're a little bit over now, 1,100 CVS Minute clinics. All of those have adopted the 4 M's of care. The state of Michigan has also taken a whole state approach with their systems, with their health department and their aging department, to make Michigan an age-friendly state. They've done that in conjunction with the Institute for Healthcare Improvement. It's been really exciting. You can see New York State listed here as well. I also want to mention, you can see the logo for HRSA and their geriatric workforce enhancement program. So they have 48 sites, all of those, all across the country, all of them are recognized as age-friendly health system sites and have a special emphasis, I should add, on dementia as part of the care from those sites. There's a logo here from GAPNA. Now, that is one you might not be familiar with. It stands for Gerontological Advanced Practice Nurses Association. GAPNA has 22 modules on how to work with family caregivers with people living with dementia. And the last one I'll call out, although every one of these is really interesting and important, is US Aging, which is the national organization for all AAAs, area agencies on aging, and other community-based organizations that serve older adults. And they lead Dementia-Friendly America. Next slide, please. Okay, I mentioned age-friendly health systems. We used to have a map for you where we, put in colors each state where there was an age-friendly health system site, but it got really boring when every single state had at least one site. So here you can see a chart that gives a sense of the over 3,000 sites of age-friendly care. So those are hospitals, they are clinics and other practices. There are those convenient care clinics that I mentioned already, and nursing homes as well, where it's really important that we have age-friendly care. So this is a movement that has been growing by leaps and bounds in the US and also globally. So these numbers are already old because they grow so fast. And as you can see here, these are from April of this year. Next slide, please. So we're here to discuss not just age-friendly health systems, but also dementia-friendly. So, why focus on age-friendly and dementia-capable health systems? Well, you know these numbers. So I'm not going to go through every word and every bullet point on this slide. What I am going to say is that as we spread age-friendly health systems, dementia is a special concern because of the stats that all of you know so well that are here on this slide. One of the M's, as mentioned, is Mentation, or mind, and it promotes screening and management of cognitive impairment. And we have a lot of other initiatives as well that are also very much working on and focused on dementia. Next slide, please. So what are some of these other initiatives, as I mentioned? So in addition to age-friendly health systems, as outlined, age-friendly public health systems are promoting dementia as a public health issue. Well, they're not promoting dementia, but addressing dementia. The US Aging Business Institute is a business institute that we support that's really devoted to helping AAAs, as I mentioned, which are area agencies on aging and community-based organizations, deliver dementia care services. And now we do this work in conjunction with ACL. So thank you to our friends at ACL. Best practice caregiving is an online repository of, back to evidence-based models for dementia caregiving. And it includes, among other things, these Alzheimer's and dementia care program at UCLA, which we support and are trying to spread to health systems to better address holistic care for people who have dementia and their caregivers. I already mentioned the 48 GWEPs, the Geriatric Workforce Enhancement Programs, and they have a focus on dementia. And then the couple of logos on the bottom left here, the GEDC, which stands for Geriatric Emergency Department Collaborative, and the Geriatric Surgery Verification. So ED and surgery both have a really strong emphasis through their standards on dementia care. So this is really important. And then last but not least, some of our policy work, again, very much in conjunction with ACL, we have done a lot of work to support the national strategy to support family caregivers. This is a public-private partnership, if you will, with ACL and with the National Alliance for State Health Policy, NASHP, to support all caregivers, acknowledging, of course, the particular needs of dementia caregivers. Next slide, please. So comprehensive dementia care is complex, and it involves each of these elements that you can see here. So I mentioned our support of the Alzheimer's Dementia Care Program. It represents a comprehensive dementia care program, which is really what is very much needed and what many of you probably know well in your jobs and in your work on a day-to-day basis. And I know that a lot of the people in our audience are advocates for dementia care. So as we see it, one of the keys to getting those kinds of comprehensive dementia care programs in place is payment. Now, you can read more about how CMS could possibly develop payment models that would support the kind of dementia care that we all believe we need in the Health Affairs article that's referenced here. It's called Payment for Comprehensive Dementia Care, 5 Key Recommendations. And this is something that we've worked very hard on, keeping our friends at the CMMI, the Centers for Medicare and Medicaid Innovation, informed of this work as we go. Next slide, please. All right, there is, I want to note that there's overlap between the age-friendly and the dementia-friendly care, and you can see some of that here. So the 4 M's of age-friendly and the 8 core elements of comprehensive dementia care, many of them are overlapping. So for example, comprehensive dementia care should account for what matters to patients, just like age-friendly health systems care. It considers things like ongoing plans and self-management to allow patients with dementia to remain independent for as long as they possibly can. There are also plenty of very direct similarities, such as medication management and continuous monitoring. And additionally, both of these models or frameworks, if you will, consider caregiver support, which is so critical because caregivers are the backbone of care for our country. We've got a number of programs at the John A. Hartford Foundation, like the Rush University Caring for Caregivers model, that focus on supporting caregivers as part of care teams. And so this is really even more important than ever in cases of dementia. Next slide, please. Okay. So how can you as a health system begin to become age-friendly and dementia capable? Well, here are 3 ways. First of all, the next action community, which is the way people learn how to become an age-friendly health system site, begins in September from the Institute for Healthcare Improvement. And you can see the link right here. You can look at existing dementia care programs to make sure they're comprehensive, supporting caregivers, coordinating care, addressing psychosocial needs. And you can do that with the best practice caregiving online resource listed here. And so this is it's a fantastic resource. I think it's up to 44 proven programs that are focused on supporting caregivers specifically of people living with dementia. So you can sort by things like your patient population to find the kinds of programs that meet needs, the right program for your needs, such as those available in Spanish or in other language, or what setting of care makes sense. Next slide, please. I want to talk a little bit about the AARP analysis of age-friendly and dementia-friendly communities. So age-friendly health systems are really a key part of a larger, what we at the John A. Hartford Foundation call an age-friendly ecosystem that we need, which includes a focus on making communities, cities, and states really age-friendly. AARP, which leads, as you probably know, leads the network of age-friendly communities, cities, and states in the US, made some recommendations on how dementia-friendly and age-friendly initiatives can work together to complement rather than to compete with each other. So among the recommendations they have are to integrate from the outset whenever possible, and for both kinds of these initiatives to review their own work and coordinate to meet the needs of both populations who are aging and those that are experiencing dementia, because they're similar but not the same thing. Key findings of the AARP and dementia-friendly report include the fact that, people often say a dementia-friendly community is age-friendly, but an age-friendly community is not necessarily dementia-friendly. So, in fact, neither one really fully encompasses the other. if you think about it. Age-friendly alone has the potential to overlook some of the specific needs of people living with dementia, while dementia-friendly communities don't necessarily consider the broader spectrum of needs among older adults as a whole. But age-friendly and dementia-friendly objectives really do share some fundamental objectives. So first of all, both of them aim to help older adults remain independent and in the community as long as possible by creating supportive and enabling environments. And in addition, both of them engage with broad coalitions of stakeholders. So this is really, building strongly together, including older people, to strengthen community supports and ultimately to increase inclusion for the benefit of people of all ages. I do want to make a sort of a quick note here that there is a movement afoot for state master plan or multi-sector plans on aging, and that's one way to go about coordinating all of these efforts. Next slide, please. Okay, so just as communities can integrate age-friendly and dementia-friendly principles, health systems can do the same. So organizations that want to become age-friendly should collect data and better understand the needs of their patients who are living with dementia and family caregivers. They should consider adopting the comprehensive dementia care models or programs with strong dementia programs, some of which you can find at the best practice caregiving site, as mentioned. And in addition, dementia care initiatives would really become just ideal participants in age-friendly health systems. They're all mutually reinforcing. And so I want to note that, I mentioned some other initiatives, including geriatric surgery and geri-EDs, for example. These are all mutually reinforcing. So the converse is true as well. Next slide, please. All right. This is our summary. Here's what we would love for you to do. First of all, join us. Encourage healthcare organizations in your communities to join the age-friendly health systems movement. And here's a link for you or anyone else you know who's interested in doing that. Age-friendly health systems should adopt those comprehensive dementia care programs that include support for family caregivers, because that's so critical. Everyone should advocate for comprehensive dementia care payment, as we are working to do. And so join us in that. And then, of course, learn more about any and all of this at our website. We're always happy to engage. So next slide, please. That's it for me. I want to say thanks so much for being here. We're grateful for your participation and support. And now I'm handing it over to Heidi, because I want to learn from her.
Thank you so much. I have to get the volume on again here. So thank you so much for this opportunity to present our work. I really think this melding of the age-friendly health systems with dementia capable work has allowed for some additional synergies for our health system, and I hope to be able to share that with you. Next slide. So this is just to ground us a little bit in what we're talking about here in Maine. So we're a state of about 1.2 million people and oldest by median age, according to some statistics. We actually share a lot of residents with Florida, where people will sunburn and go back and forth. So geography becomes a challenge. MaineHealth is 9 community hospitals in Maine and New Hampshire, and includes primary and specialty care services. We are always having to meld differences between urban areas and rural areas as we have initiatives. In addition to, I think the motto for Maine is the way life should be, and the motto for New Hampshire is live free or die. So even geography has other aspects that kind of play into some of our challenges. MaineHealth, as you can see from the map on the right, is our sites are in the southern part of Maine, and that's actually about where 50% of our population is. That being said, we actually supply care to most anyone in the state of Maine, particularly for hospital care and specialty care. Just another aspect is we consider some of the challenges, and I think it's really important to consider challenges as you enter into initiatives so that you can focus on sustainability, is that you'll note that Maine is the farthest east of the states. We are on the eastern edge of the Eastern time zone. And so as we think about our work, there's a lot of seasonal components to things that occur here. In winter, the days are short. It's often dusk by about 3:30. And it's icy and cold. And so as we think of the frame of the 4Ms, we run into challenges with mobility that are local to our state. And I think also bring up different challenges for implementation and things like that. Next slide. So as I was kind of thinking about how we brought our ACL grant work together with the age-friendly health systems, I realized it's really not linear. It's really much more like a dance. We have a lot of analogies when we're doing projects about it being a race or there's a finish line. And often it feels like, and I've heard people say when we're doing big initiatives and work, sometimes you're taking 3 steps forward and going 2 steps back. And this often makes people feel like there's a lot of wasted energy or duplication. But I think if you turn that into the frame of looking at it more like a dance, it's more about the choreography. And when someone's moving forward, someone else might be moving back. But as you bring all that together, you can really have a significant impact. And so as we take on the initiative of creating a dementia capable community and melding it with the age-friendly work, it's important to recognize the different values these initiatives bring, but how they come together to create a dance that's better than either could be alone. So I'm going to just take you briefly through the different aspects as I think of how we brought this together. So we had a ACL grant in 2017. And the 3 components as part of that grant were training the workforce around dementia, identifying it, how to work with individuals with dementia. We had a specific caregiver intervention, REACH community, REACH being resources for enhanced Alzheimer caregiver health. And then we were working on enhancing linkages between our community-based organizations and our health system. In 2018, we joined our first wave of age-friendly health system and actually started in the hospital with that. And then in 2020 began to integrate that into primary care. And so this overlapped very well with our ACL grant and the work that we've been doing. And I'll explore that a little bit more in a moment. It was very helpful to use the age-friendly health system framework to measure the 4Ms in primary care. And it really achieved commitment for our practices to move forward and do better in this area. And then we've been fortunate to be granted another ACL grant where, again, we continue to work on training the workforce because our workforce is ever changing with staffing challenges and that sort of thing. But we've also increased our focus on a population that often gets overlooked, which is those who are aging with intellectual disability and developing cognitive impairment, and then looking at a care ecosystems model and then care transitions program adapted for dementia. So we'll go on to our next slide, please. So in the next few slides, I'd like to cover some of the lessons we learned about aligning these initiatives, about the importance of being persistent, and taking advantage of opportunities, and then really using the training to create a workforce. Next slide. So in aligning initiatives, I think it is really important to think of what's happening around you as you bring on new programs. And so at the time of our first ACL grant, there was actually a lot of reorganization that was happening within MaineHealth that's not really in scope today. But one of the big focuses was around primary care growth, but also value-based care. And this brought in the aspect of really utilizing our annual wellness visit to capture much needed information. And so as we were doing this work, we happened into an opportunity where the annual wellness visit was being standardized across our organization as well as updated. And so this was a great opportunity to integrate screening for dementia into the process, but also align this with the age-friendly health work, which of course with the Mentation M or Mind M includes dementia care. We'd already had experience with the age-friendly health systems through our work in the hospital, and so it was time to transition to the outpatient setting. And all of this work aligned with the vision for MaineHealth, which is working together to make our communities the healthiest in America. As we were looking at costs of care, we also identified that people living with dementia is a really high cost population compared to matched peers who do not have dementia. And so bringing all of this together, we were able to have excellent buy-in for our initiative around screening for and managing dementia, as well as making those community connections. Next slide. So it's really important as you take on initiatives. And I think one of the things that I appreciate most about the ACL grant is, although you outline what you're going to do, the opportunity to be a little bit flexible and adjust as the grant period continues. And so as far as being persistent, I had started talking about the 4 M's, and it was really, the 4M framework was really easy for leaders who were not necessarily working in geriatrics to get their head around. And it was, me being persistent and bringing that up and making those connections whenever I could. And then eventually I was hearing other people make those connections. And so having that consistent message that other people can remember, and the 4 M's, like everybody can remember the 4 M's. It is so amazing to watch as people who don't even do geriatrics are able to repeat that framework. I also think part of being persistent is listening to what other problems people are having and trying to incorporate your initiative into the solution to their frustration. And so really the 4 M's framework can be applied to not just older adults, but pretty much anyone. And what is often good for older adults is good for everyone who's experiencing healthcare. And I think one of the most illustrative examples I had was when a family medicine primary care doctor, who was one of our leaders in starting dementia screening and integrating that into the 4 M's care, started asking the what matters question with every visit. Well, she's a family practitioner and did not only see older adults. And so she just integrated into her practice and asked everyone. And she was able to share that story. It saved her actually so much time in the end, because she wasn't ending the visits with her patients saying, "Doc, there was one more thing I was hoping that we could talk about today." By putting that right at the beginning of the visit about what was important to people for that day, they were able to actually have a better relationship and move along. And so her voice actually was very helpful in communicating this initiatives. And then, providers, physicians, nurse practitioners, I mean, none of us hate to just do things for no reason. And so by linking this with our dementia work, we were able to make connections so that after people screen for dementia, it was really easy for them to do the right thing. So it felt valuable. Next slide. I don't think we knew how much the training aspect that we had initiated with our first ACL grant would be so impactful. So as part of our first ACL grant, we created training to train our workforce. I'm talking MAs, nurses, care managers, social workers, providers about dementia. Our behavioral health partners were really engaged with that, and it wound up aligning with the age-friendly work because of the Mentation M quite directly. I think having the training with the behavioral health clinicians was interesting because they recognized how much they needed to learn in order to support people better. And so they were often counseling people who were caregivers for things like anxiety, depression, stress. And one of the issues in their lives was their caregiving role. And so one of the surprising aspects for me in this initiative was that Reach community became an important aspect to their role in providing dementia care through the support of caregivers. And that was actually one of the most sustaining aspects of our grant in the end. Next slide. So I'm going to talk a little bit about the grant that we started back in 2017. And this is a busy slide. I don't expect that you would read it, but what I want really to highlight from this is the aspects that are in the maroon circles are the aspects that were sustainable. And so these have not gone away, even though our grant funding went away. And so, on the assessment side, and for this grant, we were focused on two areas in our health system, the greater Portland area and one of our rural communities, Lincoln County. And so assessing was really important. We enhanced a Meals on Wheels assessment to include screening for dementia. And we trained many care team members in identification of dementia and what to do, as well as behavioral health clinicians. So they were ready to assess people for cognitive impairment. And so as we embarked on our age-friendly journey, we already had tools in place so that they could participate in that process. And training, we did a lot of training related to aging and dementia, and some of that has continued. The resource and referral aspect is also making sure that our neurology colleagues, as well as our geriatric center and our primary care colleagues, knew what resources are in our community for education. Next slide. So in 2018, when we joined the first age-friendly health system wave, we opted to start on the inpatient aspect because that's where we had control. We had an inpatient hospital elder life program for delirium prevention, and we knew we could control the assessment. We also knew that we were already doing really good care. And so we knew it was probably more an aspect of documenting the good work we were doing and learning from that, and then identifying our gaps and moving forward. And so that is also one of the great things about the age-friendly health system framework is that you assess, and what you find is you're doing a lot of things really well, and then it helps you hone your energies on where your gaps are. Next slide. So in advancing and spreading age-friendly health systems, with our age-friendly, we started in the hospital, we started our outpatient geriatric center where we had control, we spread through different units, including a post-acute care facility. I think one of the key pieces here was we spread it to a single primary care practice, and we were able to use the learnings from that in order to inform how we moved forward. We created a dashboard, and it helped us measure the gaps in our dementia care. And so next slide. And this shows one of the aspects, mentation, the mind includes both cognition, but also depression in the outpatient setting. And so early on, we were doing very little cognitive screening. So the slide on the left shows a 4.2%. And this was actually after we'd been talking about this for a little bit. So it had gone up from maybe a baseline of even less than this. What we were doing very well at this time was screening for depression, which we had over 90% screening for depression. And so within this mentation there's a component of cognitive screening and depression screening. And so we knew we needed to really target the cognitive screening while maintaining the dementia screening. As we created these reports, we were able to see that there were some practices that were actually doing really well with their cognitive screening and others that were doing it not at all. And so we were able to look and see how they were doing well so that we could replicate that and have them share that. Next slide. So moving into our current Alzheimer's disease partnership expansion grant. We continue to have some similar partners, our locals area agency on aging. We are working more strongly with our population health to integrate with our primary care practice so that we recognize we don't have enough consultants to see all the people with dementia. And so we need to continue to train up our primary care practices to have supports in place to manage that. And so although there continues to be referrals, we will continue with evidence-based programs to help people manage dementia. And so this is the Care Ecosystems program with a care team navigator who's going to help individuals with cognitive impairment and their caregivers really navigate their dementia process. The big area of growth for us in this is really the focus on the intellectual disability population who are aging more than they have in the past, but also developing cognitive impairment. And so we're really excited to be able to be adapting some dementia training for the providers in those group homes and community settings as well. So we're really excited for what we can do. I think communication is obviously really, really important. Next slide. And always, as we're doing this, we have to think about sustainability. What you'll need to sustain a program or offering might be finances, it might be getting buy-in, it might be actually just be creating a workflow so that people don't even realize they're doing it, which is what we did with the annual wellness visit and integrating our screening into that. During the grant period, I think you always have to reevaluate really frequently what you're doing, and what you think is sustainable might be different than you expected. For us, the REACH community, I thought we did a great job during the grant with integrating it into our geriatric center. But as soon as the grant went away, we struggled with how to get reimbursement for that. On the flip side, the behavioral health clinicians who are integrating this into a workflow and finding it really valuable, that is where we have seen the spread. And at the end of the grant period, we're able to see this was happening and able to invest more to help that continue to grow. And it continues to be sustainable to this day. I think you always have to understand what's in your scope to control when you're partnering with other organizations. And I think, you can't do everything. You can't, like, we partner with our AAAs very closely, and we can't always make them do what we want them to do. And so you have to just recognize that. I think the other aspect that I think is important to think about is duplication may be good. If you have a single person who's in charge or doing an intervention and they leave, then your program may not be sustainable. And so thinking about overlap duplication so that programming doesn't rely on a single individual. And as I said before, the ACL grant process is really wonderful for allowing for adjustment. And as we have taken on and expanded with these grants, we're getting better at identifying what's clearly going to work and where we need to have adjustments so that you can utilize the grant process to help support you to expand. And so I think next slide will be the end. And, I'm not ever sure what exactly the future holds, but I'm always on the lookout for other initiatives. And I'm really, really excited for continuing to grow our age-friendly health system work, but also using that to continue to improve our care for individuals living with dementia in our communities and their caregivers. Thank you very much for the opportunity today.
Thank you so much, Heidi and Ronnie. Great presentations. We're going to go to questions. You can go to the next slide, Cameron, that's fine. We're going to go to questions now, and you can feel free to enter those into the Q&A pod at any time. This slide is just telling you, Heidi mentioned a few times about the ACL dementia grants. This is just letting you know where you can go find information on the next round of Alzheimer's disease programs initiative grants. There's actually an opening right now that you can look at if you search on grants.gov under Alzheimer's Disease Programs Initiative, ADPI. So take a look at that. We'll get over to questions now. So Heidi, the first question is for you. A few participants were asking about the dementia training you use to train the workforce. participants were interested in knowing what the specific training was that you used and if it was done in person, online, or both.
So the training that we used was a homegrown training. And so it was originally done in person, included actually some role playing around doing the mini cog and taking people through some scenarios. And then of course, COVID hit. And so we had to adjust. And so then it moved to all online training, which then required some adjustment in how we did things. And so we wound up needing to incorporate some more videos and things like that. We're now back to still mostly doing online training because it seems like that's what people have gotten used to. But recently I've also been going around to some practices and doing some training. So it's nice to be able to do both now.
Great, thank you so much. Ronnie, there was a question that came in when you were talking. The participant mentioned that many people that are working in adult day services have been doing this kind of work over many years with all of the elements reflected in what they do. So all the 4 M's reflected. They're asking if there's a simple way to tie these into defining why it's important since they're so busy with direct daily care and support.
I saw that question as it came through, and Heidi was speaking. Well, maybe Heidi wasn't speaking when the question came through, but when I saw it, and then I felt like she answered it in a way without even necessarily knowing or intending to, which is to say, it's absolutely true that many different sites of care are already attending to the 4 M's, for example, or 3 of the M's, or pieces of the M's, but they aren't necessarily doing it as a set, which is the most holistic care for older adults. And until you go through and take a look, you don't necessarily know, and Heidi said this, what the gaps are. And so the idea is that it needs not be a huge heavy lift for those organizations that are already doing it, but it does give a framework for understanding and sort of holistically caring for older adults. So agreed. AAA's and many of the sites of care also are already very, very busy. I mean, we have workforce issues, we have burnout. What we've learned from a variety of the different kinds of sites that have done this work is that it actually brings back some joy in work because, as Heidi mentioned, it's easy to understand, it's easy to remember those 4 M's, and people have this framework for understanding how they're doing good. So I think I'll leave it there unless there's a follow-up to that.
There was no follow-up, but Heidi, if you have anything you'd like to add, please feel free.
No, I think that age-friendly framework and doing the actual measurements, it's reinforcing about the things you're doing well, but you might be surprised where you have a gap where you thought you were doing it, but you're not actually doing it all the time. And so, and then aligning with this, like there's a lot of momentum around the age-friendly health work, and that recognition may then bring you recognition as well. Even though you might not have to do that much differently or more in order to do it. I think, the what matters, I think, is often the big piece that if you're not enrolled in the initiative, you may not be doing that piece, which is truly about what's most important to the individual. It's not only advanced care planning, it's not having your POA in place. It's really like what matters. And there's some really rich conversations from that.
Yeah. Great. Thank you so much. So there's a longer question that came in that I think is really important. I want to throw it out there to both of you. So the participant is asking if there are at any point, if there were any patient or community-facing tools developed that people can utilize to plan for age-friendly and dementia-capable encounters and improve communication with healthcare providers. So is there any training to empower clients, patients, community members to drive that age-friendly, dementia-capable care? So turning the tables around a little bit.
So for us, the training really is those action communities. It's learning how to implement, how to bring all 4 of the M's of the work. And those are available to sites of care for free. They're 7-month programs. And as I mentioned, I think the next one begins in September. So anyone on this Zoom who's interested is most welcome to join through IHI.
Great.
Yeah.
Heidi, anything that you can add to that?
I would just say you can start really small. You just need someone who's really excited and interested who can then gather some other people to be excited and interested. And you can start forum care with a single individual or a single unit or that sort of thing. So it doesn't have to be like, I mean, we're across our health system now, but we didn't start there. I mean, we started where we had control. And so like as a community member, if there's some place where you have particular influence, you may be able to bring someone on board, even if at that point it's not commitment for everything, but you start one place. I just think the initiative is sort of like a snowball and it just builds and builds and builds.
Yeah. And I'll add one more thing, which it's not exactly what I think the person asking the question meant, but it is a form of workforce training. So I'm going to share that the American Hospital Association has it's like a fellowship program, but it's a practice change program. And there is a track specifically for aging. So that's for an individual to apply to become a next gen fellow. It's a year-long program, and it helps that individual who may or may not be a clinician to learn how to do these kinds of projects within their own institution, not necessarily at a single site. I mean, I mentioned earlier the VA summit that I was at. The woman who is not a clinician, who is supercharging the entire VA to become an age-friendly health system super site, I guess, was a next-gen fellow. So, and she's doing this unbelievable job as sort of one person who's gotten some additional FTE time through her work and is rolling it all out. So I put in a little plug for that.
Great, thank you so much. So just so everyone knows, in addition to all of the tools and resources that Ronnie and Heidi are mentioning, there's also many public and free tools, resource guides, and other kinds of information and documentation that were developed by ACL dementia grantees that are on the NADRC website. Those can all help organizations in their dementia capable efforts as well. And we'll push out the website to all of you so you have it and can take a look at that if you're interested. So another question that came up is, there's a few questions, Heidi, about the Meals on Wheels work. Can you talk a little bit about how it was sustained? Were you able to financially sustain the Meals on Wheels dementia assessment, or was it just embedded into the operation without additional financial resources?
I believe it was just embedded into it wasn't like a huge extension of the standard Meals on Wheels assessment, but was kind of embedded into that.
Okay, great. And then the other question that came up is, can you talk about how that screening actually works during Meals on Wheels? What is involved in the assessment? I know that that's actually.
I'm sorry, I cannot.
Okay, I actually believe that assessment is on the NADRC website.
I think it should be from our prior work, but
yeah.
Yeah, but no, I'm sorry, I can't speak any more to that.
Okay, great. All right, let me go back to my questions over here. Okay. Can you talk a little bit about any specific dementia care competencies that training has been based on? If there are any, Heidi?
So sometimes I struggle with the language people use around like the competency. So the training we developed was really designed to increase awareness of dementia among our patients that were accessing our healthcare and give people a tool they could use to kind of screen for that. And so it was pretty specific to what we were feeling the needs of the health system. So it was not designed as this training where someone was suddenly competent in managing everything related to dementia or doing all parts. So it was really geared toward what we were expecting people to do as part of their job. We have there's other educational offerings that are offered through many organizations where you can get like many hours of training, but it was really trying to focus it down into something that would be easy to give, and then very practical and useful on the other side as well. So yeah, I hope that's helpful and answers your question, but
Very helpful. Thank you. Okay. Question for one more question for you, or Ronnie, do you have anything you want to add about specific competencies that you've seen that have been useful?
Not necessarily. I mean, because it really doesn't speak to competencies so much as, evidence-based programs in other ways. And that comes back to the best practice caregiving resource that I mentioned already. One could go in and see what kinds of staff and training are needed for any of those programs that are part of the best practice caregiving online resource.
Great, thank you. Can you talk about in your programs how you manage any language barrier issues when it comes to aging issues in particular, or cognition? If you have any examples that you can talk a little bit about how you manage those.
Who is that a question for?
Oh, sorry. It really can be for either of you through the programming that you have available. If you have any suggestions or have had any situations where you've had to manage language barriers. So really open to either of you.
I think, I mean, I think, and all honestly, we all struggle with that when Maine is not the most diverse state. And so we do have challenges. We have a lot more diversity in our greater Portland area. And so we're fortunate to have access to some really good interpreters. And so I think that becomes really important, not using family as interpreter, but actually having a trained interpreter to work with you. I think, fortunately, some of the tools have different language versions, but then I think we're also having to work just really closely with the interpreters to understand. And I think all the information you gather has to be put into a cultural context as well. And so it's really hard, at least for me at this point, to say we've standardized anything. I think it's still kind of taking as it comes and trying to do the best that you can, and not letting the language barrier stop you from trying to do that and learn more and do better.
Great, thank you.
And I don't have a lot to add on that, other than to say, wherever possible, we do like to see translation. We do want to see, particularly in Spanish, which is the first one, only because it's the greatest number sort of nationally, but there are lots of communities where Chinese, Cantonese, for example, is really important. And so we are in every way possible in support of that. But the only other thing I will say is that that's where, again, caregivers are the backbone of our healthcare system in so many ways. And really, caregivers are quite frequently the translators themselves.
Great, thank you so much. I think that we are out of time for questions at this point. I just wanted to add a few more comments before we close out. First is thank you to both of our speakers. We really appreciate your presentations today. You can see that we had huge attendance and lots of questions and lots of kudos coming to you by all these icons going across the screen. So thank you so much for your time. We really appreciate it. And we also wanted to remind everyone that we will have our next webinar on August 29th at 3 p.m. Eastern. We'll be sending out the registration information for that very soon. That will be about North Carolina Senior Center's North Carolina Senior Services Memory Connections and Caregiver College. So please keep an eye out for that information. It'll come to you via email from one of the listservs that you are part of. NADRC-webinars@rti.org is the one that most of you are part of. And if you need more information, you can feel free to email us at that address. Again, that's NADRC-webinars@rti.org. So we hope to see you there, and we hope that all of you have a wonderful afternoon. Thank you so much.